Okay, so hopefully you guys got all your paperwork. We're gonna do some group work today, but it's gonna be kind of just you choose, right? Or I'm not gonna make you all get up and move around again. All right, so diving in, um, today we're talking about liver, pancreas, and gallbladder. That's kind of the focus because in our GI, they're all connected to the GI system. So, oh, no KWL today. Yeah, no KWL. I always encourage you to take notes. Think about what you know, what you want to know, what you learn. Please do that, but I'm not going to require it for this week. So we're first of all talking about the liver. So liver is hep or hepatic. So if we do word building, hepatitis is inflammation of the liver. Okay. It can be several different types. So A, B, C, D, E, right? There's a bunch. There's a graphic in your weekly resources page, and it talks about those ones. The A's and E's have to do with the GI, like fecal oral contamination. And I should have put the little graphic in there, but A and E, they're pretty much self-limiting. You get them by like ingesting, something that's not quite right. B, C, and D, D usually occurs with Hep B, so I'm not going to focus on that a lot. Oh, my clip-through went out. B and C are kind of what we look at a lot in healthcare, as far as with the chronic illnesses. So prevention is the biggest piece that we talk about with hepatitis because for the most part, they're pretty preventable. So when we think about vaccines, you guys all had to have the hepatitis B vaccine for the program, right? Why do we make sure we have healthcare providers get that vaccine? Prevention, right? Because healthcare providers, as healthcare providers, we're going to have a bigger risk of having exposure to those viruses, right? We're going to be maybe giving injections, insulin, other things where we might be exposed to those patients who have active infection. And so if we know that you have that potential risk of exposure, we want to go ahead and vaccinate against it. Also, just one thing to note, public health measures, right? That's why we have the Food and Drug Administration, why we have the, oh, what's it called when people like restaurants get the card, like the safety card? What's it called? Like the health department, yeah, there's some rating code, but every restaurant you go to should have a letter, right? A is the best, meaning they're doing a really good job of health and safety with their food. B, C, D, that means you're kind of getting a little more risky that you might end up getting hepatitis A, or you might be risking yourself a little bit. But that's why we have those public health measures, why we require people who work in food handling to have their food handler's license so they know how to properly prepare food. So some of the complications, really liver failure. That's kind of the big thing. And we're going to talk about acute and chronic liver failure. Diagnostic tests. So we've got liver enzymes, right? Liver enzymes, and we're going to talk about some of the labs in a little bit. So I'm not going to go over all of these. But if we think somebody has hepatitis, especially the chronic, they're going to do a liver biopsy. We're actually going to take a little tissue sample and test that and see how it functions. All right, so now I don't care how you go in a group. I'd like it to not be more than 4 or 5 people together, but I want you to take that lab sheet and I want you to go ahead and fill out, there's 2 things on it. And the page in your book, 654, tells you the meaning of the labs. But I want you guys to take it a step further. I want you to also think, what does that mean for my patient? If a low albumin means this, what might that look like in my patients? What's that? Oh, right over here. We'll just spend a few minutes on that and then we'll go over it together. Resume. Okay, so acute liver failure. This is going to be different than chronic liver failure. Remember way back to we talked about renal last term, and so there's acute renal failure and chronic renal failure. Same thing with the liver. I think hopefully it's the kidney failure. I hope I said that right. With your organs, you can always have acute failure versus chronic, right? So acute, usually we see this by something coming in and really causing direct harm to the liver. Most often we see it with drug toxicity with like Tylenol overdoses. I feel so bad. I would see these patients come into the ICU and they would try to overdose on like a Tylenol product, which I mean, we all know that's probably one of the worst, like that's not very effective. And what it really did was it really damaged their liver horribly and did some other things. It can cause severe damage to the liver, cause a lot of inflammation. So since Tylenol is also a big issue, right? And it's not only patients who try to overdose and take a whole bottle. There's a lot, like when we talked about upper respiratory and cold and flu, remember how so many of those cold and flu medicines have Tylenol in it? And sometimes patients don't realize, and they're taking this medicine, not realizing they both have Tylenol in it. And then their head hurts, so they also just take regular acetaminophen as well. So what is the maximum daily dose of acetaminophen? There's a lot of confusion. What's that? So right now, what your book says is 3,000. Here's how I remember that. Extra strength Tylenol, do you guys know how much is in that? It's 500 in a tablet. If you look at the bottle directions, it says you can take up to 2 extra strength Tylenol every 8 hours. So this is dosage, right? 500 times 2 is how much? 1,000. And then every 8 hours is 3 times a day. So 3,000. There are some times they would let you go up to 4,000, but you have to have that approved by a provider. You have to make sure that a lot of times they want to look at their liver function, things like that. This is something that as a nurse, I've done this before. I looked at patients and the provider maybe had ordered Percocet for the patient. And they also had an order for just Tylenol and something else that maybe had Tylenol in it. And as the nurse, I've had to say, hey, I'm concerned about how much Tylenol this patient's getting. In fact, usually, if that's the case, if my patient's having pain and we're giving all these medicines, well, actually, I'll just tell you. One of the big, well, usually what I do is I say, stop the medicines that are combined. Percocet, what are the 2 medicines that are in there? Do you guys remember? Oxycodone and Tylenol. So usually what I ask, and I'll say, hey, can we just get an order instead of Percocet for just the oxycodone? If it's Percocet 5, 325, or whatever the dose is, I'll just say, just give me oxycodone 5. I'll manage that. I'll manage the other Tylenol, but otherwise I'm going to be giving this person too much Tylenol. I don't want to do that. So that's our job as advocates to look at that. Even if we haven't hit that threshold, you know, especially if you're working day shift, be nice to the night shift, right? Because they don't want to be like, oh, now I'm at my Tylenol limit and I can't give anything else. And then they have to call the provider at night. That's something if we're working day shift, you know, it's kind of nice to do for our night shift people. Okay, moving on. So acute liver failure, what do we do for it? So it might even have to be dialysis. If it's a medication that can be dialyzed off, if that's what caused the problem, we'll do that and try to pull some of that medication, clear that from their blood. We're going to give them supportive care. We're going to give them a high calorie, low protein and low protein, low sodium diet, try to decrease the work the liver's having to do. And lactulose, we're going to give that to them. I'm going to talk about that in a minute. Eventually, it does say, oh, goodness, liver transplant for acute. Really, a liver transplant would be if the acute failure led to a chronic failure, right? If that, then they would need a transplant. So chronic liver disease, the most common cause of it is chronic alcohol abuse. So that's why we tell patients, right? Like a little bit of alcohol is not bad, but long-term alcohol abuse, especially, you know, everybody has different thresholds, but we want to monitor how much they drink because it could be causing damage to their liver. Also, the hepatitis B or hepatitis C, those infections can also cause chronic hepatitis. The pathophysiology of it, a lot of you guys, oh no, you haven't done it yet on your your papers. But if you do like your system disorder sheet, right? It's those liver cells, they get inflamed, they get scarring throughout there. The blood flow doesn't work how it should. And essentially all those good functions that our liver does get impaired. This little guy is a picture from your book, and it just kind of shows how all of these things, these systems can be affected by the liver. There was a man who actually looked very similar to this that came into my department. I was working night shift at a big hospital, and he was wackadoodle. He was really confused. He's combative. He wouldn't follow commands. I had never met him before. Family brought him in concerned that something was wrong, and we discovered he was chronic liver failure. He had was supposed to be taking some medicine called lactulose, and lactulose. I see eye rolls. Lactulose is actually a medicine that makes you poop. It makes you poop and it pulls the ammonia out of your system through your bowels, but it makes you have loose stools as part of it. Really good at pulling ammonia out of your system, which if you have this, it's hepatic encephalopathy, right? We learned about different types of encephalopathy earlier this year. This is where it's caused by your liver dysfunction. You have all of this ammonia built up in your system. So this guy didn't want to take it. Why do you think he didn't want to take his medicine? He's tired of pooping all the time, right? Can't go anywhere. And we usually, with lactulose, we have patients titrate, and it depends on the different person, but usually it's 3 or 4 bowel movements a day. Usually they'll say, take this lactulose 3 times a day, but titrate it, right? If you're having 7 bowel movements a day, maybe you only need it twice. Maybe, that the provider will usually order it to titrate, meaning we teach the patients that if you're only having 1 bowel movement a day, well, then you probably need to take 4 doses. You need to take as many doses as can make you have this many bowel movements. So he got tired of it, stopped taking his lactulose. So all that ammonia built up in his system, and he became more and more confused to the point that his family had to bring him into the emergency room. Overnight, what do you think we did? We gave him lactulose. We gave him lactulose to get that ammonia down. By the end of my 12-hour shift, he was walking around. He was respectful and nice. He was making sense. He was back to normal. But I mean, it was such a good example of how much that ammonia can really make you so confused. And some of it too with patient teaching and compliance about, he didn't want to be in the hospital. His family didn't want him to be in the hospital, but it's so important we teach them, like, you're going to have some side effects if you don't follow these things. Okay, so we talked a little bit about clotting defects, portal hypertension. Oh yeah, here we go. So here, leading into the liver, you have this portal vein. It's one of our big blood vessels in our system. When our liver isn't working like it should, it's going to cause resistance in there. So kind of when we talked about hypertension, when there's resistance in a blood vessel, it starts to get maybe a little enlarged. What happens to the pressure? Goes up, right? Goes up. If this blood is trying to flow, especially into the liver, because the liver is a big filter, if it's trying to have all that blood go through there, but there's scarring, there's damage in the liver, it can't go through as quickly as it needs to, and that blood starts to back up a little bit, and you get what's called portal hypertension, meaning there is high pressure specifically inside this portal vein. Doesn't mean they have systemic hypertension. The rest of their body, when you check their blood pressure, it might be normal, but there's high pressure here in the portal vein. What that means is that the blood vessels that are connected to the portal vein are also going to have backup pressure as well. We talked a little bit last week about esophageal varices. There's a blood vessel right here that connects up to our esophagus. That increased pressure from the portal vein then connects up to our esophagus, and those blood vessels in our esophagus have that increased pressure. And that's where sometimes they have those little like mini aneurysms almost of those veins. So that's why when patients who have liver failure, liver disease, we really want to look to see, to make sure their bleeding is okay, bleeding times are okay, because if something happens with those varices, right, if they start open and bleeding, like they're already not making those clotting factors, they're a very big risk of bleeding out. Also hemorrhoids, right? There's blood vessels that lead down directly to our rectum. These patients are high risk of having hemorrhoids as well. Same type of thing, right? It is those outpouching of the blood vessels because of that increased pressure. Okay, going back, um, hepatic encephalopathy, yeah. Okay, so diagnostic tests, we kind of talked about this, the enzymes, the bilirubin, ammonia. They're probably going to do a CT scan that might show them, make sure there's not a mass or something else causing the problem, MRI, or even a liver biopsy to actually test the tissue. This is a really good picture I pulled from the internet that shows what ascites looks like. So these patients, they get, especially with the low ammonia, not ammonia, the low albumin levels, they get that fluid edema, especially in the peritoneal area. Fluid builds up as ascites. This guy, I think it's so perfect because you can tell his pants probably fit good at one point in time, right? If he didn't have all that fluid, he could probably even button them. And then see, it's kind of hard to see, but there's like blood vessels here that are kind of bulging around. Really common to see. And some of that's from that portal hypertension that it's just like they have those outpouching or the increased pressure. He's also got like some little bruises and stuff around here, probably because he's got some low PT, like his platelets are probably not functioning super well. Does this look like somebody who's very comfortable? He's kind of leaning back a little bit. If you're a woman who's been pregnant, you maybe have felt that big, when you're like 8, 9 months, there's a lot of pressure. You can't take a full breath. You can't eat a full meal. It just pushes so much. You can't breathe as well as you need to. That's what these patients feel like. So in order to treat it, sometimes they'll use some diuretics or other things if it's mild. This guy looks pretty severe, right? He looks like he's about 7 months pregnant. They will do what's called a paracentesis, and they will take, they will take some fluid from there. This is not a very good picture, but it's the best one I could find that kind of shows you. Essentially, you have somebody who's got all their bowel and everything else that's normal, but they have this fluid that's in here. It will be a trained provider, a doctor or a nurse practitioner, physician's assistant, that under usually an ultrasound, they look with an ultrasound, make sure they see the right thing, and then they will pull off that fluid. Now, the one thing they want to make sure of, if you're pulling off a lot of fluids, you want to make sure that we're not going to drop their blood pressure really low. Even though it's not blood loss, it is total volume loss in their system. So usually, how would we tell how the patients tolerate that? What would we do before and after the procedure? Check their blood pressure, right? Because if we're taking off a lot of fluid, I've seen 10, 11, 12 liters come off of these people. So much. Now with those guys, when it's really high, we check their blood pressure, right? Because we want to know what the baseline is and to see if it drops afterwards. A lot of times for these guys, we'll also be giving them some albumin with these procedures because we know even though there's fluid in the belly, there's also swelling, there's fluid everywhere else. And we're giving them some albumin to pull that fluid back into the intravascular space so their pressure doesn't drop so low. Okay, esophageal varices. So see, this is where you can kind of see, it's like a little outpouching, right? And here they show, this is a treatment where they have banded it. I've seen it where patients have had esophageal varices that are bleeding, and they're pretty much just vomiting bright red blood. It's an emergency situation. If you have an esophageal varice that's just bleeding, they'll go in with an EGD, and they take like a little rubber band and they put it around that little outpouching blood vessel, and that will stop the bleed. So that's kind of what they're trying to show here. That's one of the treatments for it. They might also do some vasoconstriction. They definitely are probably going to be replacing the blood with a transfusion. And then also antibiotic prophylaxis, making sure there's no infection as well. Okay. Hepatic encephalopathy. Really, I feel like I see lactulose more, but you might see rifaximin, excuse me. And really what the purpose is trying to pull the ammonia out of the body. So the nurse would evaluate the patient as understanding education about lactulose if the patient states which of these. Hey, nice job. Yes, I should expect to have loose stools. Once upon a time, I had to give a lactulose retention enema to somebody because he was combative and wouldn't swallow it. And so, as an enema, we instilled lactulose. Pharmacy compounded it for us. They made it in kind of a more liquid. And then we had to, how did we do it? I think we gave it through a Foley catheter and then blew up the balloon of the Foley catheter so it would stay in the rectum and then clamped it and then left it in, I think it was a half hour. He wasn't very happy, but by having the lactulose at least there, it was able to pull out a lot of the ammonia. I'm not saying you probably will do that, but think creatively. Sometimes if you can't find solutions, somebody's ammonia is really high, we need to get rid of it. You do what you have to do. So really important with these patients that we teach them, right? Teach them about what signs and symptoms to report. We really want them to avoid narcotics, sedatives, tranquilizers, alcohol, anything that's going to put their liver at more, like cause their liver more work, more harm. Okay, hepatic case study. There is a case study that I can't give you. Yes, it's the one that has read the following case study and answer the questions. How many questions are there? I think there's 8. Okay, perfect. Are you guys a group? Okay, do you guys answer question 1? You guys are a group? You guys answer question 2? You guys answer question 3? You guys cirrhosis. You guys are group 5? Let's just take a couple minutes and then we'll go over these answers together. Yeah. Let's resume recording. All right, so during the assessment, the nurse notes there's an distended abdomen, mild confusion, and an elevated ammonia. What are the appropriate nursing interventions for this patient? Select all that apply. Okay, nice job. So we don't want to give Tylenol or acetaminophen. You all got that. The other thing we don't want to do is to place her in the supine position. Remember, if she has distended abdomen, it's probably ascites. If we lay her flat on her back, probably going to cause even more decreased space for her lungs, and she's going to have more difficulty breathing. The nurse reinforces teaching for the patient with liver disease that which of these should be avoided for safety. What do we teach them to avoid? Nice job. So anything that's going to cause more cognitive depression, right? It's going to be hard for the liver to clear, and it might hide signs and symptoms of hepatic encephalopathy as well. All right, so liver transplants, I'm not going to go into a lot about it. Really, it's just kind of like any other solid organ transplant that we talked about. You have to be a right candidate, and you've got to take anti-rejection medication for the rest of your life. You're monitoring your patient who had suspected liver cancer. They had a liver biopsy about 20 minutes ago. You gather data and notice the dressing over the site is saturated with bright red drainage. What do you do? So turn to somebody next to you. Quick 10-second thing. What do you do about this person? All right, let's compare your answers with F.A. Davis. We apply pressure, and it says gloved hands, but of course you guys know. Get a set of vitals, see how she's doing. Notify the registered nurse and or the healthcare provider and keep them in bed. We know that the liver is so vascular. There's so much blood flow that goes through it. Anytime we poke it, there's increased chance of bleeding, especially if they have some cirrhosis, scarring, things like that, or cancer that's causing dysfunction. Okay, now we have left the liver. We're moving to the pancreas. We better hop on the fast train too. So the big thing with your pancreas, we've talked a lot about it already in that it produces insulin from where? Where does the pancreas produce insulin from? Beta. The beta cells, good job. So the pancreas beta cells produce insulin. But pancreas does a lot more than just insulin production. A lot of it to do with our digestion. It secretes a lot of digestive enzymes to help us break down our food, gather all the nutrients and the things that we need from it. When there's pancreatitis or pancreatitis like inflammation there, essentially a lot of can be usually caused by something blocking the pancreas, so it can't put those digestive juices into our GI tract. It kind of just stays in the pancreas, and all of those enzymes start to digest the pancreas itself. It's incredibly painful. So usually we see inflammation. These enzymes that we see in the pancreas are very high. A lot of times there's fluid loss associated with it. A lot of times it can be from alcohol or gallstones, right? Gallstones can kind of block some of those ducts to let the pancreatic fluid come through. Tumors, sometimes they can do this procedure, endoscopic retrograde cholangiopancreatography. Sometimes when they go in and look at that, it can irritate those ducts and cause a little bit of inflammation. So signs and symptoms, severe pain. It usually is in the abdomen, but it radiates to the chest, the back, the flank. The patients are guarding. They don't want anybody to touch them. Sometimes the abdomen can be rigid. Might see high temperature or low-grade fever, high pulse rate, nausea, vomiting. If it's affecting the liver as well, sometimes it can even have some jaundice. So usually with this, it can cause, like, pain is the biggest thing. So acute pancreatitis, pain's the biggest thing. If it goes on longer term, it can affect a lot of these other organs and cause cardiovascular failure, respiratory failure, kidney failure. How do we treat it? We give aggressive IV fluids because usually these patients do not want to eat. Every time they eat, it stimulates the pancreas to produce more of those enzymes, which then increases the pain as it kind of auto-digests that area there. So they don't want to eat. If it's severe pancreatitis, a lot of times they'll give them enteral feedings. So they'll do like a Dobhoff or some sort of tube feed to give them very easy on the stomach, broken down types of nutrition. If it's mild pancreatitis, they'll let them still have oral nutrition, but a lot of times they're going to have them avoid things like a lot of fatty foods that might irritate or cause more of the pancreas to secrete enzymes. And we're going to give pain medicine. We kind of talked about this. So complications, if it continues on and is not treated, it could cause abscesses to form. It could cause a fistula. Last week we talked about bowel fistulas. It could cause opening otherwise in the abdomen as well. It could have malabsorption, right? Eventually, if the pancreas kind of stops working altogether, it gets so diseased, you could develop diabetes because then the pancreas, even though we're talking more about the like digestion enzyme portion of it, if the pancreas overall isn't working, it's not going to produce insulin as well. Chronic pancreatitis also has led to cancer as well. Remember when we talked about cancer, when you have chronic inflammation in any area, you're more likely to be, or you're less likely to be able to fight off cancer if it forms. So we look at a CT scan if we're concerned with this. We also look at their pancreatic enzymes. We'll look on their labs. Also, they're probably going to have high fat levels in their stool because the body is not going to be able to break down those fatty foods, so that you're going to be excreting more fat into the stool. Therapeutic interventions, we're going to give them where we're gonna education to stop drinking if they're still drinking, low-fat foods. We're gonna give them some pain medicine. Some of those proton pump inhibitors, decrease the stomach acid will help as well. We might give them some pancreatic enzyme replacement. Maybe if they've had a pancreectomy, sometimes they have to remove the pancreas or part of the pancreas if it continues to cause problems. And in that case, we'll give replacement enzymes for them. Okay, group work review. Oh, okay, this will be like, I think almost the last thing. So actually, let's just go through together. I don't want to waste time. So on the review sheet that has the terms, we're not going to go through the terms. I want us to go to the prioritization question. So we're going to read this unfolding case scenario and then answer the questions. All right, so the case scenario is Mr. Johnson was just admitted to the hospital with acute pancreatitis. He has severe upper abdominal pain rated as a 10 on a pain scale, nausea, vomiting twice in the last hour, serum amylase level of 675, which is high, and lipase 200, which is high. His vital signs and temperature are 99.6, heart rate 102, rests 22, pressure is 98/60. The provider ordered a bolus of normal saline, 1,000 milliliters to infuse over 1 hour, then to infuse at 150 mils an hour. Other orders include morphine, 2 to 4 milligrams IV every 3 hours PRN, NPO, bed rest with bathroom privileges. I have a hard time with this one. Chlorpromazine, compazine is easier to say. 10 milligrams rectally every 6 hours as needed for nausea and vomiting, and serum amylase and lipase in the morning. So looking at the orders from the doctor, so essentially when after the blood pressure, it says the healthcare has ordered, and then it starts with a bolus of normal saline. So looking from the bolus on to all those other orders, talk with your group just really quick and just say, how do you prioritize those things? What would you do first, second, third, fourth? Maybe there's some things you would do at the same time, but how would you know which ones to do first rather than later?
First, pain second.
There's like many different ways like owners go out about like see. Yeah, they have more. They have.
The game was a 10 of 10. Also normal same. Because it's 10 out of 10. The saline is just for hydration.
Yeah. And also he's vomiting twice.
Yeah.
All right, we're gonna finish up and go over the answers. So it says, F.A. Davis says first, it wasn't even an option, but it says, you know, since he's been vomiting, let's make sure to turn him on his side. So if he didn't, maybe we put turn him on his side, but you know, we would, if he was vomiting again, of course, we would help him on his side. Next, it says, make sure we give the IV orders. So make sure his bolus is started. Why do we prioritize the bolus over the IV pain medicine? Right, his blood pressure. His blood pressure is low. So we want to give him some more fluids to support that. And what's a side effect of opiates? It can cause hypotension. So before we give the pain medicine, I want to make sure I've got fluids started, because it might even, the pain medicine might increase or make his blood pressure even lower. All right, so we get fluids going. We give him his IV pain medicine. Next, we want to give him the suppository for nausea. We want to get that on board to hopefully stop some of that vomiting. Then we're going to make sure that he's NPO and has assistance getting to the bathroom. Then we're going to make sure lab has the orders to get his labs in the morning. How'd you guys do with the prioritization? Fair? Yeah, okay, we're gonna keep practicing. The next morning when you return to work, Mr. Johnson now rates his pain as 7 out of 10, was last medicated for pain 3 hours ago. He reports nausea. Actually, I don't want to finish this. I want to do something else. Sorry. I really wanted to get through the prioritization because I feel like that has a lot of benefit for you. I'll publish the answers to the rest of these so you can look over them on your own time. I don't want to miss our gallbladder stuff because there's not a lot, but there's a little. Cancer of the pancreas. Really, the biggest thing I want you guys to know is that cancer of the pancreas often is caught late because the signs and symptoms are very vague until the cancer is quite advanced and often has metastasized. Very painful. Just like we have pancreatitis, it's very painful. Often cancer of the pancreas causes pancreatitis. Very painful. This is a nice little comparison box you can use when you're studying about different signs and symptoms and how hepatitis, liver cancer, and chronic pancreatitis all have some similarities and differences. So gallbladder, some of the word building, I just want to make sure we understand. Cholecystitis. So chole is gallbladder. That's the word building. The first part for gallbladder is chole. And then the itis, cystitis, that's inflammation of the gallbladder. Now, cholelithiasis, those are stones in the gallbladder. It's not the gallbladder itself, but there's stones that are inside the gallbladder. And then we have choledoctolithiasis, and that's when you have stones in the gallbladder. Oftentimes, cholecystitis is caused by cholelithiasis, or these stones that are blocking the gallbladder duct. It can't excrete anything. So increases risk with age. A lot of times, if you have family history of gallbladder issues, you might have increased issue. It's more often seen in women and oftentimes after pregnancy. A lot of times you'll see postpartum women have issues with their gallbladder producing gallstones. So it's something that we look at often for our postpartum women. Signs and symptoms, sometimes they can be silent, but a lot of times it's vomiting, jaundice, anything that's causing irritation to that area, including the liver. It's usually associated with when they eat, it hurts. Right upper quadrant pain, wait, that's left, right? So put your right upper quadrant, that's usually where it's hurting at. Complications, it can get severely inflamed. In fact, it can even become necrotic as well. It can cause pancreatitis as well. We usually look with an ultrasound, but also we'll follow up with a CT scan. Give them pain medicines, anti-nausea medicine. Oftentimes they get very nauseous. With these guys, a lot of times they end up having to have surgery. Sometimes they said medication to dissolve stones. Usually they are given if the stone is blocking. I don't love this picture here, so I'm not going to explain it. Sorry, I meant to take it out. Usually what they're going to do is they're going to go in and try to break up those stones, remove those stones. Sometimes they have to go ahead and just totally remove the gallbladder as well. Priority nursing diagnosis for a patient who just had an open cholecystectomy. What do we think it might be? All right, we follow our ABCs. Ineffective breathing pattern is going to be the right one because, right, they're going to have impaired skin integrity. They're going to have pain. They're probably going to have fluid volume shifts, but right after surgery, they're still waking up after anesthesia. It's going to be that impaired or ineffective breathing pattern. And one thing to note, open versus closed. You guys remember with surgeries what open means? It's like a big incision, like the traditional incisions where they do like a midline incision, open, do the surgery. A laparoscopic cholecystectomy is usually what you'll see where they do the laparoscopic, like a little incision in your belly button and a couple of like side incisions for the instruments. But the open one, that's going to have more pain, right? It's bigger. causes people to have more trouble breathing, not trouble breathing, but they don't want to breathe as much because it's more painful to take those big deep breaths. Oh, good, that's the end. Okay, so don't forget to turn your homework in if you haven't already. I'll post the answers to the rest of the case studies and the stuff today so you can check what those answers are. For transition today, we're going to go over a lot of like the law and legal things today. We're actually going to gamify it and do another Jeopardy. I've got candy, so come hungry, maybe eat as well. Let's come back at 12:35 for transition today.
I can't, you guys were going over the test, and I was like, oh, God,